السلام عليكم.
Waalaikumsalam, Doctor.
السلام عليكم. Can you hear me?
Waalaikumsalam. Yes, Doctor.
We can start by الكتاب. Okay, let us start. How many presentation today?
7 topics, but 4 presenters. Can you hear me, Doctor?
Yes. Again, how many presentation today, please?
We have 7 topics and 4 presenters. So there are presenters who will be presenting.
Let us start by the first one, please.
Okay, Bismillahirrahmanirrahim. So my name is Nurul Aiza binti Zaidi, and I'm going to explain endotracheal tube intubation and also nasogastric tube insertion. So I'm going to start with endotracheal tube intubation first. Okay. So this is the outline from my presentation. Okay, so first of all, what is nasogastric? What is endotracheal tube insertion? So it's basically a procedure of inserting a flexible tube through the mouth down into the trachea. So what are the indications and contraindications? Okay, so for the indications, when there is failure of oxygenation and also ventilation. So clinical evidence of respiratory failure should be checked, such as poor respiratory effort, cyanosis, and also impaired mental status. And then to maintain and protect the airway in severe systemic conditions such as shock, hypotensive shock, and then patient under anesthesia. For diagnostic and therapeutic procedures. And lastly, in diaphragmatic hernia in newborn. So for the contraindications, it is actually contraindicated in an inexperienced operator. So in this case, the clinician should perform the back mask ventilation and wait for the and ask help from the pediatrician and also the anesthesiologist to help with the intubation. In emergency situation, there is no actually absolute indication, contraindication, except if the patient has advanced directives or healthcare plan where the patient condition is against the advanced airways placement or endotracheal intubation. And the relative contraindication when we anticipate difficult airway with concern of difficulty either by back mask ventilation or difficult to intubate itself. Okay. Next, the equipment that we use. First and foremost, the bag and mask with high oxygen flow. So this is the bag mask system. Can also use the non-rebreather mask. And then when we position the mask, we must select the mask size that fits the nasal bridge and also the chin of the patient. So if you see the correct picture here, the mask should fit the nasal bridge and also the chin of the patient without covering the eyes. So this is the correct size. The rest is wrong. And then for the bag, the mask and bag, so we use in infants and young children, we use the pediatric bag with a tidal volume of 400 to 500 milliliter. And for older children and adolescents, we can use the adult bag. So next is the laryngoscope. So laryngoscope, as the name suggests, larynx and scope, right? So this is an instrument to visualize the larynx in order for us to insert the tube. So there are two types of laryngoscope. The first one is the straight bleed, or the most common that we use is the Miller standard bleeds. And the second one is the curved bleed, or the most common one is the Macintosh standard bleeds. So for the Miller standard bleeds, it is a straight bleed and it provides excellent exposure of the glottic opening. And the sizes are designated as 0 to 4, and it is usually for infants. So the straight bleed, usually we use for infants. So you can see the bleed number here. You can see here, it has actually 0, 0. I will explain later. And then 0 to 4 sizes. And for Macintosh as well, it is a curved bleed and it provides a good view of the oropharynx and hypopharynx. The sizes are designated to as 1 to 4, and it is usually used for older children and also adult. Okay. So for the laryngoscope bleed, so this is the size of the bleed. Bleed 00 is actually for extremely premature neonates. And then for bleed 0 to 1, we use in preterm and full-term neonates. Bleed size 1 for infants, bleed 2 for 2-year-old children. And at this age, we can already use a curved bleed. And then bleed 3 for each 10 and above. So you can see here in the picture, the clinician is assembling the bleed and also the handle. And then you should always check for the light resources so that it works. Next is the tube itself, the endotracheal tube. So we have the cuffed. We have two types, cuffed and uncuffed. So for the cuffed type, it actually has the inflatable cuff. So you can see here, it has inflatable cuff, which it can seal the airway against the oropharyngeal contents and prevent air leaks. And in the uncuffed ETT, but in uncuffed ETT, it often have large air leaks and often necessitating to larger size tube. But in children, actually, we use a lot more for uncuffed ETT instead of cuffed ETT because in children, from what I've read, in children, they wanted to reduce the risk of injury to the airway due to the due to the inflatable cuff itself. And also because children, they have a narrower cricoid. So the cricoid ring itself can already act as the seal airway. Okay, so in order for us to use the ETT in children, we need to calculate both the diameter, and these are the formulas for the cuffed and uncuffed, and also the oral ETT length. And these are the formula in neonates and also children more than 1 year old. Okay, next is stylet. This is optional. And then suction catheter, because sometimes the oropharynx secretions can be excessive. So it will be difficult for the clinician to see inside the larynx. So we suck the secretions. And then pulse oximeter, scissors and adhesive tape, ECG monitoring, sedation, and also muscle relaxant. But when we use muscle relaxant, you need to be careful in patient that we anticipate having difficult intubation. Okay, so you can use this stop MAID mnemonics to remember all of the equipments that we have discussed just now. Next is preparations. So if possible, pre-intubation checklist is preferred. So this picture is actually an example of a pre-intubation checklist for COVID-19 pediatric patients in Hospital Tunku Azizah Kuala Lumpur. Okay, so this is like one of the example. And then we can also use the Lemon scoring system. So what is Lemon? It is actually a mnemonic. So the L1 is look. So just look at the patient. Look externally if there is facial trauma, if the patient is obese, large tongue, definitely the beard is not applied here in pediatric. And then for the E is actually evaluate. So what do we evaluate? We evaluate the distance of the incisor, the hyoid, and also the thyroid. So the 3-3-2 rule is actually three fingers. So whose finger is patient's finger, not our fingers. Okay. So the first 3 is actually for the opening of the mouth, the incisor distance. So we look if the mouth is big enough, the opening is big enough to fit the three patient's finger. Okay. And then another 3 is from the hyoid, from the mantle, the chin to the hyoid distance, and then from the hyoid to the thyroid distance. And then Malampati score. Malampati score is a grading system from grade 1 to grade 4. So what does it grade? So it grades the visualization of the anatomical structures inside the mouth. Okay, so grade 1, good visualization, and grade 4 is extremely difficult to visualize. Okay, and then O, obstruction, and then N is neck mobility, because in order for us to do intubation, we need to extend the neck. So if the patient's neck is immobile, it will be difficult for us to intubate the patient. So don't worry, if you don't understand what I'm talking about just now, you can always read this again. These are all the explanation for the Lemon just now. Next is the informed consent. So what are the key components? If possible, you need to inform to the patients and also to the caregiver. So the components of the discussion should include the medications that will provide sedation and also pain control throughout the procedure. The endotracheal intubation may not be successful. So we need to also explain what will we do next if the intubation is unsuccessful. Okay, next is the personnel and equipment. For the equipment, you can just remember the stop MAID. And for personnel, at least 3 persons. So the team leader, the airway provider, and also the respiratory therapist. And if possible, the nursing staff can also be there. So when you form a team like this, the key point is to understand and to know who will be handing the ETT to the intubator, who will be securing the tube and provide positive pressure ventilation, and who will be observing the patient's vital signs. So everyone needs to know what they need to do. So team leader plays a major role in here. Next is, okay, now we are in the procedures. Okay, so before we know the procedures, it's very, very, very important for you to know the anatomy first. So on the right picture, I've included what are the differences between the child and also the adults larynx anatomy differences. And this is what, on the left picture, this is what you're going to see when you do the laryngoscopy later. So you need to be able to recognize the epiglottis and the glottic opening, and then the arytenoid cartilage, the posterior cartilage, and then area epiglottic 4, vallicular, and also posteriorly vocal cord. So on the picture below, these are the two important openings that you need to differentiate: the glottic opening and also the esophagus opening, because we don't want to intubate the esophagus. Next is so now we are starting the procedure. Okay, so for the pre-oxygenation phase, first you need to put the child in a sniffing position and continue back and mask ventilation up to 3 minutes if necessary with 100% oxygen. Okay, so what is sniffing position? So this is the correct sniffing position. Okay, the glabella and the chin are horizontally aligned, the neck is extended, and then the external auditory meatus and the sternal notch are horizontally aligned. And these on the right side, these are the example of incorrect position. This is way to this is way to extend hyperextended. This is underextended. And then after you put the child in the sniffing position, monitor the child's vital signs as well. Okay, so after sedation, and neuromuscular blocking, perform a Caesar maneuver to open the mouth before laryngoscopy. So on the right, you can see the picture. This is how to do Caesar maneuver to open the mouth. And then next, using your left hand, introduce the blade into the mouth and then advance to the back of the tongue. So the movement should be to the back and down. So despite of dominance, you need to hold the blade, the laryngoscope, using your left hand. Okay, so on the second picture here, just below the Caesar maneuver, you can see the doctor is using the left hand, the clinician using the left hand, and then the tongue is retracted. Okay, you can see it is retracted to the left side, actually, slightly to the left. So once the tongue and the soft tissues are retracted, the clinician should recognize the aforementioned anatomic structures, such as the epiglottis, the alternate cartilage, the posterior cartilage, and also the esophagus. So when the epiglottis is seen, lift the blade upward and outward to visualize the vocal cords. Okay, so you can see the picture below. On the left is the real larynx. On the right is the dummy larynx. So A is the glottis, the glottic opening, B is the vocal cord, and C is the epiglottis. That's why when you already recognize the epiglottis, you need to lift the blade upward and outward. So when you lift the epiglottis, definitely you can see the vocal cord in the here. Okay. So in case of the structure, the epiglottis or the glottic are not visible, so the clinician should pull the blade slowly until they are visible. And if still not possible, then we can use the Selig maneuver, or basically putting pressure on the cricoid. So you can see here, while another person is doing the laryngoscopy, another clinician should press the cricoid here, so that the clinician can visualize better the epiglottis. Next, so just now, you remember, right? We hold the laryngoscope using the left hand. So now using your right hand, you hold the endotracheal tube and insert it into the trachea. So like this picture, you can see the right hand, the clinician is inserting the tube. So suction if necessary. So like I've mentioned before, if the oropharyngeal secretion is excessive, you can suck them out. And then always keep the glottis in view and insert the endotracheal tube along the vocal cords. Okay, when it's open, so you can insert the ETT until the desired length is applied. So if intubation, okay, that's that. So if intubation is not done within 20 seconds, the attempt should be aborted. So the patient needs to be reventilated again with bag and mask. And once intubated, once the intubation is successful, remove the laryngoscope on the left hand, and now hold the ETT firmly with the left hand again. Okay, so, and then connect to the self-inflating bag and positive pressure ventilation. And then how to confirm that we have intubate correctly. So you can look at the chest expansion, make sure the chest expansion is equal. And also the lungs air entry also equal on both lungs. And then secure the ETT with adhesive tape, connect it to the ventilator, and then insert orogastric tube to decompress the stomach and check the chest radiograph. So when you check the chest radiograph, the endotracheal tube should be below the clavicle and above the carina. Yeah, above the carina. Okay, next, complication and pitfalls. Okay, so these are the complications. So first one is esophageal intubation. So you might intubate correctly, but then it displaced into the esophagus, and then right lung intubation. So when the endotracheal tube gets into the right lung, the right lung will be hyperventilated, while the left lung will be hyperventilated, right? So now the left lung is lack of oxygen. It can cause lung collapse on the left lung, and then trauma to the upper airway, pneumothorax, and subglottic stenosis. Okay, next. Moving on to the second procedure, which is nasogastric tube insertion. These are the outlines of my presentation. Okay, I'm going to make it quick. Okay, a nasogastric nasogastric tube is a long, thin, and hollow tube which is passed through a nostril of of the nose. Okay, a nostril of the nose into the pharynx and down into the stomach. So what are the indications and contraindications? So for the indications, because we want to provide the enteral feeding, we want to feed and to deliver the medication in patient who is known or suspected aspiration risk, depressed mental status, poor pharyngeal muscle control, with endotracheal intubation, or poor appetite. And then in patient with the compression of GIT, assessment for assessment and treatment of upper GI bleeding, and to aspirate gastric secretions or air in patients that require continuous drainage of gastric secretion, such as in patient with apa kita panggil? What is it? It's okay. I forgot the word. I'll come back later. Okay. And then aspirate air from the stomach. Okay, next is the contraindications. So presence of any nasal, facial, or basilar skull fractures, or disorders of esophagus or stomach, such as esophageal atresia, severe esophageal stricture, and gastric perforation, and perform in caution in patient with esophageal varices, patient on anticoagulant therapy, or patient with bleeding disorder, especially when patient have thrombocytopenia, a platelet count less than 50,000. Next is equipment. So first one is definitely an nasogastric tube. So we have three types, the sum tube, stylated tube, and also non-stylated tube. So sum tube is only for aspiration. So we don't use sum tube for feeding. And for stylated tube, usually for long-term placement. And non-stylated tube is for short-term placement. Okay, so these are the other equipments: anti-reflux valve, suction connector, tape, gloves, catheter tip syringe, gastric pH paper, lubricants, and also suction sauce with a receptacle. Okay, next, preparations before we do the nasogastric tube insertion. So definitely informed consent if possible. So explain in appropriate terms to the child or caregiver on the rationally why we do this, and also the procedure briefly. And then obtain verbal informed consent from the caregiver. And place specialists can also be there to distract or familiarize the patient with the procedure in case if they are scared or not comfortable to be in the hospital. Next is measurement of the NG tube. Okay, so first we prepare the equipment just now. Make sure your hands are clean or use or wear gloves. And then we must use the correct size of NG tube and measure the appropriate length. So just like endotracheal tube just now, for NG tube, we need to also use the appropriate tube size. So on the right, I've already included the tube size according to the age. And we need to measure the appropriate length after this. Okay, so first, have the child sit up straight. Okay, so for infant, lay the baby face up with their chin slightly raised, and then hold the tube, the end of the tube, at the nostrils of the child, and then we will start measuring from there. Okay, so moving on. So this is how we measure the length. Just now we measure the tube size. Now we measure the length. So in infants less than 1 year, how do we measure? So from the bridge of the nose just now, right? Remember, we start here at the nostril. So from the bridge of the nose, and then moving on to the ear loop, and then halfway between the Z-fod process and the umbilicus. So here, the point is here. Okay, so but in older children or infant more than 1 year, we measure from the nostrils to the ear loop and then directly to the Z-fod process. Okay, we don't, in infant, we halfway between the Z-fod process and umbilicus, but in older children, directly to the Z-fod process. Next, we are into the procedures. Okay, so for the procedure, the first one is to the NG tube placement itself. Okay, so step one, have the child sit upright like this, or in younger children who cannot sit on their own, the parents can hold them. And in infants like this, lay them down and bundle them in a blanket so that their arms and legs are not moving. Next, lubricate the tip of the NG tube before you insert them. So in children less than 6 months, can use water for injection. Water for injection is basically sterile water. So, and then child more than 6 months old, you can use the water for injection or water soluble lubricants. And for long-term feeding tube, the internal tube should also be lubricated by flushing with 2 to 3 milliliters of water for injection. Okay, and then step 2, lubricate. Step 3, insert the NG tube via nostril. So the angle of the tube should be down toward the back and also down. So you can look here in the picture how they push the the tube. And then step 4, you can actually offer a sip of drink using a straw, if appropriate lah. If patient is older children, because the swallowing action will facilitate the passage of the NG tube. Okay, so you can ask them to swallow or just ask them to sip a drink. So actually in infants, sometimes when they cry, they cry and while swallowing also. So it might actually give advantage to us. They are crying, but it is an advantage to us as well because they are swallowing the tube as well. So in step 5, advance the tube until the marking is seen at the edge of the nostril. So just now we already measured the length, right? So you can mark and then after you measure, you can mark it or you can tape it. So then when you insert, just keep inserting until you see the marking here. You see the marking and then you stop. But caution, when patient remove the NG tube immediately if the child is coughing, gagging, choking, or become cyanotic, because this might indicate that the tube is actually in the trachea. So we need to pull them out right away lah. If the distal end of the NG tube appears in the mouth, right? So when you try to from the nostril and then suddenly it enters the mouth, you must remove the tube and let the child rest again. So don't try right away. Let the child rest again and recover before trying again. And if the NG tube is unsuccessful after 2 attempts in both nostril, the first nostril and the second nostril it unsuccessful, and then you can ask a senior nurse or experienced doctor to have further attempt. If still unsuccessful, just continue procedure for a while lah. Okay, next. So now we already insert the NG tube, right? So how do we confirm? Always need to confirm, okay? So step 7, checking the NG tube placement. So using a catheter tube syringe filled with 5 to 10 milliliter of air. So you can see in the picture, right? This is the syringe. It's just basically air inside. And then push the syringe and then listen for a gush or rush of air in the stomach. Okay. So, but note in mind that in smaller children, you can actually hear the rush of air even though the NG tube is actually in their lungs. So you cannot use this technique in small children, in neonates, infants. So how do? We verify by aspirating the gastric content using the anterior syringe size to 2.5 to 5 milliliter lah. Basically, we obtain the aspirate and test for pH indicator. So the color on the strip should be less than 5. So less than 5 is okay, meaning we know that it's already in the stomach. But for children who are on stomach acid suppressing medication or have just fed, the color should be less than 6. We can accept under 6. Okay, next is procedure. The ending lah. Once we are done with the checking, and then we secure the NG tube to the skin. Usually we want to avoid giving pressure to the nasal cartilage. So we tape them at the cheeks. So you tape them at the cheek, and then add the connector and also anti-reflux valve and connect to the suction. You can also apply mittens to an infant to limit the access to the NG tube because they love to move, right? And then consider a chest X-ray for any patient whose condition deteriorates shortly after NG tube placement. So always check the NG tube before using the tube for feeds or medications. And if a new tube is inserted, any concern on displacement of NG tube and when the child is choking, vomiting, coughing, or having trouble breathing, like I've mentioned before, it might be in the trachea. So we need to verify again and again. And lastly, the complications. Okay, so these are the complications. Pulmonary intubation, pneumothorax, displacement, aspiration, urinitis, sinusitis, and so on lah. Okay, so you can read this. So this is basically all my presentation. So I've presented 2 procedures. So I open for question. Anyone has any question?
No question? Okay, so let us do some points, please. Discuss some points. Number 1, for any procedure, you must know what you are going to do. Okay, even in Islam, there is a completed chapter in the Bukhari. العلم قبل العمل. If you are going to do anything, you must be knowledgeable about it. Thank you. We can understand now this procedure, but at the start we must introduce ourselves to the family or to the baby, and good permission. Infection control must be routine. because or our intervention, if not sterile, it can cause severe sepsis. Okay, with the ET tube, the most important is ventilation. So even before trying to do the intubation, you must do ambu bagging and make the oxygen saturation at least nearly 100%, because you are allowed to do the ET tube within 30 seconds maximum. So 30 seconds is a long time for anyone. Okay, so you must be prepared by high oxygen, and then you must limit your time to 30 seconds. Okay. Thank you for this lemon juice in the morning. Okay, the other thing for using the laryngoscope, I know you are not away, you are away from the hospital, but some people are catching the laryngoscope as if they are catching weapon. It may be for adult, the situation are very difficult, they can catch it, but for us, we are carrying it as a pen. The laryngoscope for infants and the children must be very smoothly. You are by left hand only, but not by right hand. And as your colleague show us now, we just introduce, no need even for rocking, because all this, the tip of the laryngoscope can injure the baby. And you need to just to lift as the picture in front of you until you can see the vocal cords. Also for vocal cord, you are not so hurried because vocal cord is open and closed with the cycle of respiration. So if you found it closed, don't try to knock. Wait until it opens there, then you can pass. Okay, this is a very important point for that. For OGT tube, it is a very simple OG or NG. Very simple procedure. You will, inshallah, practice it, and also sterilization and measuring and everything are very important. Okay, good. Any question? Okay, let us go for the second presentation.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Can you guys hear me?
Yes, we can hear you.
All right. So my name is Muhammad Akib Mohsin. My matric number is 1812001. So today I will explain 3 procedures: venipuncture, blood pressure measurement, and also the peripheral intravenous cannulation. So I will start with venipuncture. So venipuncture is a surgical puncture of vein, especially for the withdrawal of blood or for the intravenous medication. So it is more preferred in term neonates as it causes less pain than the heel pricks procedure. So these are the equipment needed. So we need gloves, needles. So for needles, we usually use 23 gauge and basically lower than the 25 gauge. And then we can also use a butterfly needle because it can provide an easier access and also movement of the needles. And then we need the hub, the evacuated collection tubes, the alcohol wipes, syringes. So for syringes, the barrel volume of the syringe, we need to estimate the volume, and usually use 1 to 5 milliliter, because if we not determine the correct barrel volume, uh, the larger syringe usually will cause a collapse of the vein. And then next, we need bandages or tape, gauze sponges, iodine swab or wipes, requisition form, tourniquet, and also shops container. So for the site of venipuncture, we usually do at the forearm. Usually we puncture at the median cubital vein or the cephalic vein. So before we do any procedure, we need to identify our patient. So we can use the wrist or the foot band only if it is attached to the patient, and do not use the bed number or a wristband that is attached to the bed or the cot of the patient. So if there is a presence of the parents or the legal guardian of the patient, we can ask the person for the child's first name and also the last name. And lastly, we need to check the name, the date of birth, and the hospital or file number are written on the laboratory form, and match them to the identity of the patient. So for the procedure, firstly, we need to prepare the needle and the syringe. We need to use the winch steel needle, usually like 23 or 25 gauge, with an extension tube, or we can use a butterfly needle. We need to keep the tube and the needle separate until the needle is in the vein. Next, we need to collect supplies and all the equipments. And of course, we need to perform a hand hygiene before we do the procedure. So if there is a presence of the parents or the guardians of the child, we can ask for the guardian if they are willing to help in immobilize the baby or the child. So, but if the parents or the guardian is not willing to help, we can ask for assistance. And so next, we need to put the tourniquet on the patient about 2 finger width above the venipuncture site. Next, we need to put on a well-fitting non-sterile glove. And then we need to attach the end of winch infusion set to the end of the vacuum tube, and insert the collection tube into the holder until the tube reach the needle. And then we need to remove the plastic sleeve from the end of the butterfly needle. We need to disinfect the collection site and allow it to dry. And then we need to use our thumb to draw the skin tight before we puncture the vein, about 2 finger width below the venipuncture site. And then after we puncture the vein, we need to push the vacuum tube completely onto the needle. And next, we need to check for flashback in the tube. So the blood should begin to flow into the tube. So after that, we need to let the blood fill in the tube until it is full, or until the vacuum is exhausted. So if we need to fill multiple tubes, we need to carefully remove the full tube and replace with another tube. And we need to also take care not to move the needle in the vein, so that the needle will not displace by the vein. And after the required amount of blood has been collected, we need to release the tourniquet. And we need to place a dry gauze over the venipuncture site and slowly withdraw the needle. We can ask the parent to continue applying the mild pressure. And then we need to remove the butterfly from the vacuum tube holder and dispose of the butterfly in the sharp container, as well as the contaminated supplies. And then we need to label the tube with patient identification number and date. We need to put an adhesive bandage on the patient if it is necessary. And we need to remove our gloves dispose them appropriately, and also we need to perform hand hygiene at the end. So that's all for venipuncture. Next is for blood pressure measurement. So this usually indicated for chronic disease patient, or for if the children have a symptom of hypertension. So basically, the children will show the symptom of hypertension if the patient have the second stage hypertension. And for example, like the symptoms are loss of vision, double vision, chest pain, abdominal pain, or headache. So for infant, they usually show, they may seem irritable, and they cannot be fed properly, and also there will be a lot of vomiting. And some of the infants usually will diagnose with failure to thrive. And for it also indicated in children in emergency department or intensive care units, as well as the high-risk infants. So what is high-risk infants? High-risk infants is infants that are clinically it appears well clinically, but they have higher chances in developing a clinical problem, such as hypothermia, hypoglycemia, or infection. Basically, high-risk infants is for infants that born preterm or born with a low birth weight. And it also recommended for children more than 3 years old to have their blood pressure measured annually as part of a routine preventative health screening. So for the cuff size, we need to really determine the correct cuff size for the children, because the most common error in blood pressure measurement is when we use the inappropriate cuff size. So the considerable overestimation can occur if the cuff is too small. So the recommended bladder length by the American Heart Association is 80% of the patient's arm circumference, and the ideal width is at least 40%. So basically, it determined by the age. So if newborns and premature infants, usually 4 times 8 centimeter, the infants usually 6 times 12 centimeter, and also for older children is 9 times 18 centimeter. So there are two methods of measurement, either direct or indirect. So for direct methods of measurement, the catheter is placed directly into an artery to obtain the blood pressure measurement. This will give the most accurate measurement, but it is invasive and it only used in an intensive setting. So the indirect method of measurement, there are 4 types of indirect methods of measurement. The first one is manual cuff and sphygmomanometer. The step of using manual cuff and sphygmomanometer I will explain later. Basically, the disadvantage of this is the observer and also the methodology errors can occur. And next is the ambulatory, which is monitors the blood pressure during 24-hour period. This is a valuable method for assessing or managing a suspected hypertension. And next is automated oscillometric device, but this device can be inaccurate. And the last one is Doppler ultrasound. These are the least used in clinical setting nowadays because it only useful for systolic blood pressure, but it's unreliable for diastolic pressure. So this is Korotkov sounds. So Korotkov sound, we need to know about the Korotkov sound if we do a manual blood pressure measurement. So basically manual blood pressure measurement is when we use when we use the auscultation during the measurement. So when we auscultate the radial artery, after we deflate the blood pressure cuff, phase 1, there will be an appearance of clear tapping sound. So this correlate with systolic blood pressure. And phase 2, the sound will slowly become softer and longer, but there is no clinical significance. And phase 3, the sound will become crisper and louder. Also, there is no clinical significance. But in phase 4, the sound become muffled and softer. So it usually indicates an alternate measure of diastolic blood pressure. And in phase 5, the last phase, the sound will disappear completely. And this indicates the diastolic blood pressure of the patient. So before I explain about the procedure, the tips to ensure a correct measurement. If the patient consume caffeine within the past 30 minutes, we need to delay the blood pressure measurement. And we need to always make sure the arm is free of clothing. We need to expose the arm completely. And while obtaining the blood pressure, neither the patient nor the person obtaining the blood pressure should talk. And for the position of the arm, the brachial artery should be at the level of the heart. So because if the brachial artery is lower than the heart level, the reading will be higher. And if the brachial artery is above the heart level, the reading will be lower. So this is the procedure for manual blood pressure measurement. So first of all, we need to have the patient to be in seated position or lay down. Basically, the patient needs to be comfortable, relaxed. The legs must be uncrossed and the feet resting on the floor. And the arm should be supported at the level of the heart, like I said before, and slightly flexed at the elbow. So we need to place the blood pressure cuff with the bladder midline over the brachial artery pulsation. So how to estimate the right blood pressure cuff position? The lower border of the cuff should be about 2.5 centimeter above the antecubital crease. And in the first step in the blood pressure measurement, we need to determine the inflation level. So how to determine the inflation level? We need to palpate the radial artery and rapidly inflate the cuff until the pulse is disappears. So after it is disappeared, we need to read this pressure on the manometer. And when we want to estimate the systolic blood pressure, we need to add 30 millimeter mercury to it. So after we found the inflation level, after the radial artery is disappeared, so we need to deflate the cuff and wait for 15 to 30 seconds. And then we need to place a stethoscope lightly over the brachial artery. So and then we need to inflate the cuff rapidly to the predetermined inflation level. Means we need to inflate to the level that we found before, and then we need to add 30 millimeter mercury to it. So if, for example, the inflation level is 100 millimeter mercury, we need to add 30. So we need to inflate the cuff to 130 millimeter mercury. And then we need to turn the bulk screw counterclockwise in order to deflate slowly the cuff at a rate of 2 to 3 millimeter mercury per second. So during the deflation of the cuff, we need to note the level at which you hear the sound of at least 2 consecutive beats that indicate the phase 1. So like I said, this will represent the patient's systolic blood pressure. And then we need to continue deflate the cuff until the sound become muffled and later on will be disappear. So it indicates the correct cough phase 5, which is represent the patient diastolic blood pressure. So in order to confirm the disappearance of the sound, we need to listen as the pressure falls for another 10 to 20 millimeter mercury. And then after we get the patient systolic blood pressure and also the diastolic blood pressure, we need to deflate the cuff rapidly. We need to read the systolic and diastolic level at to the nearest 2 millimeter mercury. we need to record the blood pressure, the arm use, the arm position, and as well as the cuff size use. And if we need to repeat the measurement, we need to wait at least for 2 minutes before we do another the same measurement. And then the next one is automated device. This is the more simple measurement where we need same as manual blood pressure measurement. We need to have the patient seated position, uh, comfortable, relaxed, and the legs uncrossed, the feet resting on the floor. And for a younger children, they may sit on the parents' laps for 2 to 5 minutes before obtaining the measurement. And then the arm should be supported at the level of the heart. We need to place the automated oscillometric cuff on the arm. And then we need to initiate the automated device, causing it to inflate and then deflate by itself. And then we need to record the blood pressure, the mean arterial pressure, the arm use, the arm position, and the cuff size used. So same as manual, if we want to repeat the measurement, we need to wait for at least 2 minutes. So that's all for blood pressure measurement. The last one is peripheral intravenous cannulation. So intravenous cannulation, it is defined as a cannula or catheter that is inserted into a small peripheral vein for therapeutic purposes, such as administration of medication, fluids, or blood products or blood components. So it indicates, it can be indicated in a short-term period or in a long-term period. So for a short-term period, it is indicated for delivery of intravenous fluid, medication, as well as the blood product administration. For a long-term indication, it usually indicated in a repeated medication delivery, chemotherapy, immunotherapy, total parenteral nutrition, as well as extracorporeal procedures such as hemodialysis or peritoneal dialysis. So for the catheter selection, it's determined by the age of the children. If the patient is newborns or infants, we need to use 22 to 24 gauge. And for older children, we need to use 18 to 20 gauge. And as you can see on the right hand side, there is a picture of the catheter selection. It shows the color coded catheter and what is the recommended uses for the catheter. So basically for pediatric patient, for infusion, and for routine blood transfusion, we use the blue color and also the yellow color. And then the site for cannulation, the most preferred site is at the upper extremity and usually at the forearm, where we can cannulate at the cephalic vein, the basilic vein, and median cubital vein. Basically, the easier vein to cannulate is the median cubital vein. And we can also do at the dorsal vein, for example, like dorsal metacarpal vein. Why we prefer to do in the upper extremity? Because if we cannulate at the upper extremities vein, it is more durable and it usually associated with fewer complications compared to lower extremities. So if the upper extremities vein is not accessible, we can cannulate at the lower extremity vein, for example, like great saphenous vein and also a dorsal vein. But in adult, the cannulation at lower extremity vein usually it's associated with high risk. It associated with high incidence of complications such as thrombosis and also embolism. But in infant and in children, the risk to develop the complication is lower than adult. So it is acceptable to cannulate at the lower extremity vein for children and for infants. And the last one is a scalp. We can cannulate at the small superficial vein of the scalp. This is rarely useful during cardiopulmonary resuscitation, but it can be helpful in the less urgent situation. The cannulation at scalp, it is less desirable because we need to shift the head of the children in order to expose the vein. And this also can cause the parents to have unnecessary concern about a needle in the head of their children. So the equipment for cannulation, we need glove, alcohol swab, tourniquet, ethyl chloride spray, catheter, transparent dressing, heparin saline, which is the anticoagulant, T-connector, and rubber band. Okay. Technique for peripheral intravenous cannulation. First, we need to identify the vein, and then we need to secure the identified limb and apply the tourniquet. And then we can apply a topical anesthesia with a occlusive plaster for an hour earlier before the cannulation, or we can spray with ethyl chloride for a short procedure. And then we need to clean the skin with alcohol swab. And then we need to puncture the skin and advance the needle or the catheter in the same direction as the vein at 15 to 30 degrees angle. And after we puncture the skin, we need to advance the catheter a few millimeters further. So once there is a flashback in the hub, or once there is a blood appears at the hub, we can withdraw the needle slightly while advance the catheter over the needle. And then after that, we can remove the tourniquet and flush the catheter with heparinized saline. And then we can secure the catheter and connect it to either a rubber band or to IV drip. And then we need to immobilize the joint above and below the side of the catheter insertion with a restraining board and tape. So next is the complication that may be developed after we do the cannulation. The most common is hematoma or bleeding. Next is thrombophlebitis after a few days of cannulation. And the last one is extravasation that can lead to a soft tissue injury that will result in limb or digital loss, and as well as the loss of the function. So these are my references. Is there any question?
Napib?
Yep.
All of you need to revise how to write the references. I think one of the group just can do the international way to make our references. It is not like I did book or that book. Must be the author and the chapter and which part of the but a very important procedures, despite for some it looks basic, but it is very important, and we must know all details and even some extra detail for that, so we can get the accurate measure. It is very important. Also, how to prevent any complications, okay, like venipuncture. Usually, most of the unit are doing the thrombophlebitis, any extravasation. It must be recorded, and we can make like incident report just to know where is what's wrong. Okay, it is very important. But when I came to Malaysia in the first time and found this shop DIY, I asked what is DIY. They said do it yourself. Is it correct?
Yeah.
Yes.
Can you? Yeah. So really, I found this a very good job. Everyone can do a lot of things. So please, don't put your hand like that. Any procedure, you must be able to observe. We are giving you marks for observe, then assistance for, and then for doing. We have 3 stages. Even in most of the issue. See one, do one, help one. Yani see something and then do it. And then if you are experienced, you just learn another one. This is a very important point to have skill. And remember that your value in medicine is your skills. Okay? So you must every time and then you get new experience and be very, very, very professional for that. Okay? Good, Naqib.
Right. Thank you.
Any questions? Okay, let's go for the next presentation.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Nurain Anissa Jiha. Okay, my name is Nurain Anissa Jiha binti Azmi, and I will explain about the chest physiotherapy and suction for the procedure presentation today. So first, this is my outline, the table of content, what I will talk about today. So let's proceed to the chest physiotherapy. So normally, there is just the right amount of mucus in lungs, but in some children that having respiratory illness or when lungs become infected or irritated, a lot of thick mucus is produced. So this is why chest physiotherapy is needed. It is a treatment that helps remove this mucus from the lungs, because as mucus in the lung will cause airway obstruction and hence cause difficulty in breathing. So first, this therapy include postural drainage or positioning, percussion, vibration. And usually this procedure is followed by a productive cough or suctioning of a patient. So indication, it is useful for individuals with copious mucus or teeth secretion and help in loosen and cough up thick or excessive lung secretion. For example, in a patient that having atelectasis, in which some or all of our lung tissue are collapsed, lung infection may be like pneumonia or lung abscess, COPD, bronchiectasis, where the large airway in lungs are damaged and widened, immobility. So the chest physiotherapy can help prevent pneumonia and other breathing problems due to the long-term immobility. Pneumonia and cystic fibrosis, where the genetic disorder that cause thick and sticky mucus build up in our lung and cause difficulty in breathing. So next is assessment. First is we must assess the vital sign, assess for the patient if he have any contraindication that might stop the procedure to be proceed, and then perform detailed physical examination or review patient x-ray. And then methods for the procedure. First is percussion. Percussion is you must put a thin layer of cloth, never percuss over the bare skin, and then you can use a cup hand or percussor cup. If done right, popping sound will be heard. Percussion should not cause any red marks on the skin of the patient, and also it does not cause any pain. Do not percuss below the rib, because it is believed that when you percuss below the rib, it can cause damage to the child kidney, liver, or spleen, and do not percuss over the backbone, breastbone, or lower two ribs. The percussion should last 3 to 5 minutes per area, but some reference also shows that 2 minutes is also sufficient for the percussion. It's depend on the amount of the mucus that need to be drained. So the area that have a lot of mucus may need more time for the percussion. And then good time to the chest physiotherapy is in the morning, where your child is not eating yet, because it can remove the secretion that have built up during the night, and also night right before the sleep, so that the child will have a restful sleep. Next, how we percuss is we can use a traditional method, which the hand is cupped as to hold to hold the water, but the palm is facing downward. Or you can use the percussor cup as shown in the picture 1. So vibration is a gentle shaking pressure applied to chest wall to move secretion into a larger airways. So you place a flat hand firmly against the chest wall. They vibrate the chest wall as the patient exhales slowly through the purse sleeve. So this is to loose and dislodge the airway secretion. And then position. So position the child so that the part of the lung to be drained is higher. So the force of gravity will help to draw the secretion to the larger upper airway, where it can be coughed or suctioned out. And also note that we must put the patient and also the one that doing the procedure in a comfortable position. So you can place the child on your lap, and always have the child knee and hips bent to help him or her relax and to make coughing easier. So this is the procedure for the chest physiotherapy. First is apical segment, as you can see for the first picture, where the infants are leaning slightly back, percuss over the area from the nipple line to the shoulder on both sides. So you can percuss each area for about 2 minutes. And then second picture is posterior segment, with the child is leaning forward. You can percuss over and above each shoulder, blade on the both sides, and also 2 minutes on each side. And then the third picture is middle lobe and lingula segment, where the child is lay flat on his or her side, and then you roll back 1/4 turn with arm extended. So you percuss over nipple area, and then after that you can repeat on the opposite side. And then the fourth picture, you place the child in a flat position on his or her side with arm extended as shown in the picture, and then you percuss over side of the rib cage below the armpit. And for the anterior basal section, you place the child in a flat position facing up, and then you percuss over margin of the ribs on both sides, and do not percuss on the stomach. And then the last picture is posterior basal section, where you place the infant in a flat position facing down, and then percuss above the lower margin of the ribs on the both sides. And then contraindication in the chest physiotherapy actually is all relative, including increased intracranial pressure, unstable head or neck injury, active hemorrhage, and also rib fracture. So that's all for the chest physiotherapy. Moving on to the suction. Suction is described as the mechanical aspiration or pulmonary secretion from a patient with an artificial airway. Suction can be applied to either the upper airway or the lower airway. So it is a medical procedure to clear a retained or excessive secretion in respiratory tract to facilitate the airway expansion. And need to be noted that this is an invasive procedure, so it only need to be carried out if indicated and not on the routine basis. So the routes involve nasopharyngeal, oropharyngeal, endotracheal, and tracheostomy. This is the main functions. The main aim for this procedure is to to maintain the patent airway so that the patient can breathe effectively in their own. So when there is sign of respiratory distress or evidence of unable to cough up, so the suction might be indicated in the patient. And also, suction can be used to obtain sample secretion for diagnostic purpose, such as sputum, to get the sputum for any diagnostic for the any disease. And then methods. So this is the equipments, roughly the equipments for the suction. And then first is nasopharyngeal suction. As you can see, first is we know that before we make any medical procedure, we need to put ourselves in a sterile position. So you must wash your hand and etc. And then after you can prepare the equipment, and then you can prepare the patient, such as if the patient is most of our patient is underage, so we need to have a parent's presence to make the child relax. So first is you make the head of the children at the 30 degree, and then you must make sure the oxygen is nearby just in case if there is any complication during the procedure. So first, you hook up suction to catheter and test if the suction is too high or not, so that it is suitable for the child later. And then you lubricate the catheter to avoid any trauma to the child. And then you can measure, as the first picture show, you can measure the catheter from the child nose to the ear. And then you can hold on to the baby head to avoid the babies moving when doing the procedure. And then you gently insert catheter, but not with suction yet. And then after the catheter was inserted fully, then you can apply the suction. And then after that, you can remove the catheter and note if any color or odor at the catheter. So that's for nasopharyngeal. This next is oral suction. Oral suction is basically it is just the same, but the route is different. So first is you apply the suction into the side of the mouth, as the first picture shown. And then the second picture shows that you can go around under the tongue or a little bit up over the tongue and try to get any poo secretion in the back of the throat. And do be careful for the patient that have a gag reflex, or if the patient was fit beforehand, because to avoid the patient vomit during to the procedure. And then next is endotracheal suction. Endotracheal suction. Endotracheal suction is a sterile unit. So mostly we did this in about 10 seconds. So first, you need to having someone to assist you during this procedure. So you ask your assistant to hyperoxygenate the patient. So this is to provide some oxygen reserve for the patient during the procedure. So what is hyperoxygenate? Hyperoxygenate is when you give the patient 100% of oxygen via ventilation. And then you maintain one sterile hand, as the second picture show. You maintain the sterile hand and one dirty hand to connect to the suction bag. And then before you proceed to the procedure, you need to observe the patient oxygen saturation, because just in case to make sure that the patient is stable enough to proceed to the procedure. And then after that, you can insert the catheter, but do not apply the suction yet, just same as the procedure before. And then after that, you can, when the catheter is inserted, you can start apply suction. And when you are done with the suction, after 10 seconds, you can pulling the catheter using a peel rolling technique, where you put the catheter between your finger and the thumb, and then you just move it in opposite direction, so the catheter will be pulled out in a circular motion. And endotracheal, and then tracheostomy intubation. First is you connect catheter to the suction source, And then you can put 3 to 4 drops of sterile saline into the tube of the tracheostomy. Do pre-oxygenate a child if needed. And then dominate hand is to pick up the catheter, while the thumb opposite hand is control the suction part. And then after that, you can withdraw the suction using rotation method. And then after you're done with the procedure, you can discard the catheter with the glove. And contraindication, just the contraindication is in the patient is severe bronchospasm, acute pulmonary edema based on skull fracture, or if the patient having any obstruction in their respiratory systems. And this is my reference. Yeah, that's all.
Can I see your reference?
Sorry, you want to see what?
References.
Oh, reference.
Yeah. Nuriana now is doing a good job for her references. I think inshallah we will do one standard for all of us. Just present it to me, and then we will give for all, for any presentation, for any seminar, you must go through it. Anyone has a question for that? Again, let me remind you, as a pediatrician now, most of our chronic cases is treated by multidisciplinary team, not one team only. You cannot do all the job. So usually you need like physiotherapy for the suction like that, occupational therapy, speech therapy, whatever, neurology, urology, subspecialty. So it is very important to know while you are still young, to know for every detail. You must know some things about. This one is very important for suctioning, which you will do it routinely for any patient admitted if he has a lot of secretion like that. So all these are very important, but just remember that the adjusting pressure is a top importance. I mean, the pressure for the preterm baby is only 60. For full term, between 80 and 100, more than 100 is contraindicated in neonates because it can cause trauma. Sometimes it can cause pneumothorax. It can cause bradycardia, a lot of side effects. So you must know the pressure for every age, pediatric, adult, because even some staff nurses used to put the suction pressure to the top, which is 400. It's very dangerous to be used for pediatric like that, okay? So even for everything, for every procedure, we must be cautious for certain point, please, okay? Okay, that's good. Next one. We have Sasmid Salat Haga. So I hope we can finish, inshallah, within 20 minutes.
Okay, my name is Muhammad Armari Beda Malik. I'm going to present about the heart, weight and occipital frontal circumference, and also ECG today. Next. Okay, firstly, I'll present about length assessment, which is done for children under 2 years old and below. We use measuring board, and we need 2 persons, one to position the baby and one to measure. Need to place baby in supine position, and the measurement is reported to the nearest 0.1 centimeter. Next. For the height assessment, for the children more than 2 years old, we use stadiometer or standing height. It is performed without shoes. We take 3 measurements and take mean to ensure the greatest accuracy, and then we plot the graph on the standardized growth chart, growth curve. Yes. Okay, for the children below 2 years old and below, for the weight assessment, we use calibrated weighing scale. The infant should be weighed without clothing or diapers, and the measurements should be reported to the nearest 0.1 kilogram. For the children more than 2 years old, to assess weight, we use standing weighing scale. We remove shoes and little clothing and take measurement to the nearest 0.1 kilogram and plot on standardized growth chart. And then we go into the occipitofrontal circumference, or we know as head circumference, to measure in the children up to age 3 years old, because the development of brain occur at this time. And we measure using flexible measuring tape and measure at the maximum diameter through the supraorbital ridge to the occiput, and take measurement for 3 times and take the largest value. And then we reported the measurement to the nearest 0.01 centimeter and then plot the graph. This is just to give you a picture where is the supraorbital ridge and occiput, and this is how we measure the circumference. We can consider it as macrocephaly if the measurement is greater than 2 standard deviation above mean, and macrocephaly if the measurement is smaller than 2 standard deviation below mean. Next. We must to take note that OFC can be affected by thick hair and cranial bone deformation or hyperostosis or hyperdevelopment of bone. So we must plot the head and what simultaneously, because sometimes the OFC is normal, but it is not appropriate to the body growth. And we measure head circumference of the children with abnormal head and what as well. Next. This is just to show the growth chart for the boys. Next. This is the growth chart for the girls. Next. And this is the growth chart for the preterm that we need to focus on. We need to check for the weight, head circumference, and length to focus whether it is normal based on the gestational age. Yes. Yes. So if there is an infant with the head circumference 2.5 standard deviation above normal for weight and gender, we need to take certain steps to investigate. Next. For example, this is the step that is recommended to investigate. We determine whether it is real or not. If it is true macrocephaly, we proceed to the next box and then just follow the box on the procedure. Next. There is many cause of a large head in infant. For example, increased pressure, increased pressure from interference in cerebrospinal fluid, hydrocephalus from aqueduct stenosis, and then large cranium with or without large brain, also increased skull bones or with cranial hyperostosis, or apparently large head, which means that large in relation to body but on normal center when plot. Okay, next. Okay, we go to the ECG.
Before ECG, this measuring the weight, height, and head circumference, it must be very professional, because we are not rely on single measure. Usually, we must have, we call it as a centile chart. Means centile, I must have a lot of measures, okay? If in between this measure, someone did unprofessional job and give us an odd one, like the head circumference, like the weight, like the height, it will disturb all the story. So please take care about the accuracy as you presented already. It is very, very important to be restricted for that. For many measures also, we are getting sometimes the mean. But for the head circumference, it is better to measure 3 times, and we will retrieve which one, Arman?
Yes.
For the head, for the occipitofrontal circumference, if you measure 3 times, which one you are going to retrieve? The smallest, the largest, the one intermediate?
The largest.
The largest. Yes, this is a very important, because the head circumference in different position is different. So we are retrieving the largest one. So every time, especially if you suspect there is hydrocephalus or microcephaly also. Microcephaly is very important to be diagnosed, because it carry a risk for, unless it is familial, it carry a risk for a lot of cases like brain atrophy, like that. So it must be measured 3 times and retrieve the highest one. Okay, go now for ECG.
Okay, next. So ECG or EKG, which is very common to us, used to measure the electrical activity of the heartbeat, to check for the heart rhythm or check any abnormality of the heart and see if you have a poor blood flow to the heart muscle. Next. Usually you use 12-lead ECG. There is 10 electrode required to produce 12-lead ECG. 4 electrode on all four limbs in the right arm, right leg, left arm, and left leg. And 6 electrodes on the chest, V1 to V6. 3 bipolar limb lead, lead 1, 2, and 3, which is used to see the electrical activity of the heart from the specific angle. 3 augmental unipolar limb lead, AVF, AVR, and AVL, and 6 precordial chest lead, V1 to V6. Yes. So this is the placement of the lead. As you can see, there is 4 in the right arm, right leg, left arm, and left leg. For the lead 1, positive electrode on the left arm and negative electrode on the right arm. And the lead 2, positive electrode on the left leg and negative electrode on the right arm. For the lead 3, positive electrode on the left leg and the negative electrode on the left arm. Next. This is the placement of the lead for the V1 to V6. As you can see, lead 1 in the 4 interpreter space, right margin of the sternum, and then many specific place to place the lead V1 to V6. Next. And each of the segment and the label of the ECG can represent many things. For example, in the P wave, it represents the atrial depolarization from SA node to AV node. And the Q wave represents septal depolarization. Left bundle branch that is depolarized. And there is many specific process that represent each of the segment of the ECG. Next. For the pediatric ECG lead placement, for the lead 1, we put at the nipple line to the right of the sternum, lead 2 nipple line to the left of the sternum, and then lead 4 below the nipple at the mid-clavicular line, lead 3 midway between lead 2 and lead 4, lead 5 entry axillary line at the same level as before, about where the ribs curve back, and lead 6, mid-axillary line same level as V4 and V5, as we can see in the frame. Next. This is indication of contraindication for the ECG. It is indicated in the myocardial injury, ischemia, infection, electrolyte abnormalities, drug toxicities, diagnosis of cardiac disorder. Usually there is no absolute contraindication for the ECG, but some patients may have allergies or sensitive to the adhesive use on the lead. Next. Next. We know that in the pediatric ECG, the ECG result can be slightly different because at the birth, the right ventricle is larger and thicker than the left ventricle, and this reflects the greater physiological stress that is placed upon in utero, because the uterus have to pump blood to the high resistant pulmonary circulation. For example, we can expect to see ECG picture that resemble the right ventricular hypertrophy in adult. For example, marked right ward disease, dominant R wave in V1 and also T wave inversion in V1 to V3. Okay, next. And this is the normal finding that we can expect to get from the pediatric ECG. Heart rate that is more than 100 beats per minute, which is normal for the children. And right ward QRS exists more than 90 degree, or we say right axis deviation, T wave inversion in V1 to V3, RSR pattern in V1, right ventricular hypertrophy as a normal anatomy, and also short PR interval and QRS duration. Next. So this is the preparation that we need to do for the ECG. We have to wear loose clothes so that it is easy to take off or undo. And we need do not apply any lotion or ointment to your child's chest before the scan. And we need to ask the child to lie on the bed next to the ECG machine, and the technician will apply some sticky sensor pack on the child's chest. And those sensors will then connect with wires to the ECG machine, and then we can record the heart activity of the child. Next. This is the example of the normal ECG in age 1 year. That is resemble the right ventricular hypertrophy in that which is normal. Next. This is the normal pediatric ECG for the healthy 2-year-old boy that display many of the typical features of the pediatric ECG. For example, heart rate of 110 beats per minute, which is normal for the age. We can see in the lead V1 to V3, this is dominant R wave. Also RSR pattern in V1, also juvenile T wave pattern or T wave inversion in V1 to V3. Next. So this is normal value for the heart rate in children that classified based on the age and the heart rate. You can see there is a certain heart rate, mean of the heart rate and the range that is normal for the certain age. Next. And this is just the ECG characteristic for the certain age group. For example, in the premature infants, below 35 weeks gestation, the left and posterior QRS exists. Relative left ventricular dominant, a smaller R in V1, taller R in VC is normal in this age group. And there is many ECG characteristic that is specific to certain age group. Next. And this is normal values in pediatric ECG that we can see also. In the certain age, there is a different normal value for the PR interval, QRS duration, R wave amplitude in the lead V1 and lead V6. Next. This is the guideline for you all how to interpret the pediatric ECG. For the rate, for example, we count the number of complex and multiply by 6, or count number of big box between R to R interval and divide by 300 by that number. For the rhythm, make sure that it is a sinus rhythm. There must be a positive deflection of P wave before QRS complex and lead to an AVF with a constant per interval and negative deflection of P wave at AVR. For the P wave, there is very little changes during the course of life. You might expect whether it is same or just a little changes. For the PR interval, normal per interval varies with age. Prolonged per interval more than 0.16 second indicate AV block for first degree, secondary, or third degree heart block. Next. For the QRS complex, we need to do to see if there is a right ventricular hypertrophy, which is normal in pediatric after the first 6 months of life because of the greater physiological stress. Normally, newborn have electric axis more than 135 degree, or right axis division, which is normal at this age. Axis is calculated by looking at lead 1 and AVF. RSR pattern on V1 indicate right ventricular hypertrophy, and QRS duration is measured with the lead that have the longest QRS duration, which can indicate the ventricular mass that will increase in mass as the child growth. This is formula for the QT interval that will reflect the total duration of ventricular depolarization and repolarization, and this is formula, or we call as Bazet formula, that we can count for the ST segment. A normal ST segment is isoelectric and gradually into the T wave. T wave, inverted T wave in V1 to V3 remain until the age of 10 to 15 years, where the T wave become upright in V1 and V3. And then T wave gradually become positive as the age of 10 to 15 years old. Next. And this is my references. Thank you.
Any questions? Okay, I think theoretically now we are prepared if we are going to make a one file for all this project together, inshallah, after the simple corrections which I asked for it. All of us must go through it, and inshallah soon we are coming back to the world. At the time we can understand what's our responsibility. Let us observe 1 and 2, then let us assist 1 and 2, and then let us, inshallah, with time we are able to do it ourselves. We have the second half of the group. When they will be ready, either ready at the moment or waiting for the next week.
Next week, Doctor.
Not yet ready?
I believe not yet.
Sorry.
I think not yet. I think they are. We are all prepared for next week for seven positions.
Okay, you are paying the timetable. So next week I am not. I have no time on Wednesday. So we need to shift it to another day. Also for the procedure, I think we need to shift it maybe at for your group, we can do it, inshallah, on maybe on Monday afternoon or evening, can be?
Yes, we are free at that time.
So we can just do it maybe after Maghrib? Or after Maghrib?
After Maghrib. Oh, okay.
Or we can, yeah, because I think if we start at 6 p.m., it will be very difficult for Maghrib.
Yes.
MashaAllah, you are doing a long presentation. Is it okay to start from 8 to 10 or not suitable for any of you?
Okay, Doctor.
Okay?
Okay.
Yeah, it's okay.
Okay, Doctor.
Faiz, is it okay?
Yes. I'm
Okay.
free during that time.
Okay, good. Should be free. So instead of our procedure on Thursday, we will make it on Monday. Okay?
Doctor, actually in the timetable on Wednesday is a seminar. On Thursday is procedure presentation. So are you available for seminar on Wednesday?
So for seminar, I'm not free
Yep.
also,
Dermatology.
neither 16 or 17.
Oh.
Yes, but the seminar, if you need, I can do it also afternoon. From 8 to 10,
On
Wednesday.
on
same day.
Wednesday. Oh, okay, okay. Seminar on Wednesday
Okay.
and procedure on Monday.
Okay. And switch the Thursday to Monday at 8 p.m. Okay. See you, inshallah. I think there is new regulation that you may come at the end of this month, inshallah, to the hospital. We will tell you welcome. And then all theoretical knowledge which you got, you are asked to apply, inshallah. Before leaving you, any other point do you need to discuss with me or any questions?
Doctor, I would ask, how do you
Yes.
interpret or describe a growth chart of a child? How do you interpret a growth chart?
Yes, this is a good, important question. You can present the growth chart for 1 minute. Can you, who is the one who presented the growth chart, can present it again?
You mean the screen?
Yeah.
Then Nakib should present the screen, right? The slides.
Until you present, yes, good. So we are using the accurate measure, accurate methods, okay? As you did like this, and then come to the growth chart, we will find the two color. Yes, fix this one. This color is pink. So it is for girls. Usually they love the pink color, so we did it for them. The blue color for the boys. So if you put girl on a boys, it will look very small, or boys on the girl, it will be like that. So you must know the correct chart, okay? And accurately you are doing like that. You just measure the weight and plot it in the weight centile, and then go to the head circumference, measure it 3 times and plot it, and then you can come for the length, okay? You will find after that there is gross velocity and many things can be done also. So you must plot and see. It will guide you. Inshallah, I am not the one to giving you this growth and development. You will find many growth chart which can guide you. If the patient usually on the same line, okay, for all, it may be either familial or it can be constitutional one. If you find some child who was growing good and then started to drop, you are going, that's why we said it is not only one measure, it is centile, many chart. If it started to drop, we will see, is it malabsorption, it is hormonal, whatever. If it started to be increasing, is it obesity or morbid obesity or another syndrome? That's why, to be very meticulous, just you can put one drop on that as a marker. Okay? Is it your question or you need to ask any other detail?
I think it's understood for now.
So you must plot here, there, and this child on the 10th centile for all. This child is in the 3rd centile. So for neonate, I will say Again, Afriana.
Sorry? Oh, it was stuck just now.
Again, what you said?
Oh, just now, your mic was
Okay.
stuck.
So this, sometimes we need to say this child has IUG. Okay. See you, inshallah, on next Monday. And just remembering me, please, early morning on Monday. Okay.
Okay, Doctor.
Thank you. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.
Waalaikumsalam.
Thank you, Doctor.